So today we are going to discuss congenital heart conditions, which includes two types of diseases. One are the cyanotic heart conditions and the other are acyanotic heart conditions. So the cyanotic heart conditions, cyanotic and acyanotic. The acyanotic heart conditions, these include the ventricular septal defect, the atrial septal defect, the patent ductus arteriosus. These conditions, there is a shunt that causes blood flow from the left side of the heart to the right side of the heart, and whenever there is a blood flow from the right side of the heart towards the left side of the heart, then the condition will be it will called cyanotic heart condition. There also you can remember it by the terrible T's. So there are 5 T's. There is tetralogy of Fallot, there is transposition of great vessels, then there is persistent ductus arteriosus, and then there is tricuspid atresia, and total anomalous pulmonary venous return. So all these they starts with T, and they are known as the terrible T's because they causes cyanosis in the early life. They are also known as blue babies because right after birth there is cyanosis, because the left side is responsible for providing oxygenated blood to the body. So when there is the blood flow occurs from the right side, which is deoxygenated towards the left side, so cyanosis will appear very early in life. The acyanotic heart conditions are known as blue kids, not blue babies, because they causes blood flow from the left side to the right side. So the right side it deals with the blood but under low pressures. So eventually when the blood flow increases quite much, and the pulmonary hypertension develops and pulmonary hypertrophy occurs. So what happens is the blood flow on the right side, it pressures increases too much, and the blood eventually reverses and it moves from right side to left side. So when this shunt reverses, it causes cyanosis. We will discuss this later in Eisenmenger syndrome. That's why they are called blue kids. So acyanotic heart condition causes cyanosis but later in life. So it's written here. It's written here that left to right shunt are acyanotic at presentation, and cyanosis may occur but later in life. When will the cyanosis occur? It will occur later in life because at birth the flow is from the left to right, so it does not cause cyanosis. But later in life, when pulmonary vessels become thickens and right ventricular hypertrophies, the right sided pressures they increase, and untreated acyanotic heart condition eventually results in shunt reversal. A shunt reversal from left to right to left. This is called Eisenmenger syndrome. So right to left shunts, they will cause early cyanosis, and they are the true cyanotic heart condition. Whenever we say cyanotic heart condition, we refers to them. The left to right shunt also causes cyanosis later in life, but they are called acyanosis on the basis that they does not cause cyanosis right after birth. It causes years later when they are left untreated. So then there are two types of cyanosis, the central cyanosis and peripheral cyanosis. So whenever the cardiac output is normal and blood flow is not enough, blood flow is flowing, but it has not enough oxygen, it is known as central cyanosis. The extremities are warm, they are receiving blood, and in the peripheral cyanosis what happens is the blood flow is decreased, and then there are cold extremities in the peripheral cyanosis. So the first condition, the right to left shunts or the cyanotic heart condition or the terrible T's, what happens is that causes early cyanosis or the blue babies. It is often diagnosed prenatally or even after birth, and it requires urgent surgical treatment or the maintenance of PDA. Whenever there is a congenital heart condition, which causes early cyanosis. We need a shunt like a VSD or a PDA. We want to maintain that PDA or VSD so that the blood to the lungs is delivered through that shunt. If we close that shunt, it will cause immediate death of the baby. So the first condition is truncus arteriosus. Truncus arteriosus. It is due to the failure of the neural crust cells. The neural crust cells are responsible for forming the aorticopulmonary septum, which we discussed in the first video. That the truncus arteriosus, it fails to divide that pulmonary trunk into pulmonary artery and aorta. And why? Due to failure of the neural crust cell to migrate. Due to failure of the aorticopulmonary septum formation, most of the patients also have an accompanying VSD. So the truncus does not divide into these two structures. It does not give rise to a separate aorta or a separate pulmonary trunk, due to which the blood mixes, and it is also associated with an associated VSD. It is usually related to maternal diabetes, and the transposition of great vessel, it is also related to maternal diabetes. So in the transposition of great vessels, what happens is, as the name suggests, that the two of the great vessels, what two? One is the pulmonary artery, pulmonary trunk, and the second one is the aorta. These two exchanges its place. The aorta needs to arise from the left ventricle, but here it arises from the right ventricle, and the pulmonary trunk, it arises from the left ventricle. So what happens? There are two parallel circuits of blood, and they does not mixes with each other. See, from the right ventricle, the blood, instead of going to pulmonary trunk, it goes into aorta. So the deoxygenated blood is delivered through the whole body. Similarly, from the left ventricle and the pulmonary trunk, it arises from the left ventricle. So it provides blood further to the lungs, and again from the lungs the blood come to the left ventricle, and this way it gets oxygenated, while on the right side the deoxygenated blood is distributed throughout the body and again collected through superior and inferior vena cava to the right ventricle, and eventually again distributed to the whole body. So there are two parallel circuits. Two parallel circuits are developed, and there is no mixing of the blood. So this kind of circulation is not compatible with life until there is a shunt, and that shunt is either a VSD or a PDA or a patent foramen ovale, which allow mixing of the blood. If there is no mixing of the blood, the child soon after birth it dies. So there we therapeutically keeps the PDA open. So due to failure of the aorticopulmonary septum to spiral, so there is no spiraling, and here what happens is the aorta, due to arising from the right ventricle, it is anterior in position to the pulmonary trunk. That's why it gives an egg-on string appearance on the, this is an egg-on string appearance on chest x-ray. And without surgical intervention, most of the infants die within first few months of life. So this is very important. The next is sometimes there is a rare variant. This is called detransposition of great vessel. Sometimes there is a rare variant called LTGA, or it is also known as congenitally corrected TGA. It is called double switch, in which along with the aorta and the pulmonary artery exchanging its places, the left ventricle and the right ventricle also exchanges its places. So it is congenitally corrected itself. Like the aorta, instead of arising from the right ventricle, it arises from the left ventricle, but on this side. And similarly, the pulmonary trunk on the from the right ventricle. So it is congenitally corrected. But eventually, even those patient does not survive, because the right ventricle is not able to deal with such high pressures as aorta is arising from it. So eventually the right ventricle fails. Now what happens in the tricuspid atresia? In the tricuspid atresia, as the name suggests, that the tricuspid valve is not formed, it is absent, or it is the hypoplastic right ventricle. So what happens is, when the right ventricle when the tricuspid valve is absent, there is no blood flow from the right atrium towards the right ventricle. So all the cases either needs ASD or VSD for viability, and through that ASD or VSD blood moves to the lungs. If it is not present, the patient will not survive. Similarly, the tetralogy of Fallot is a very important disease. In this disease, what happens is it is known as tetralogy. Tetralogy means there are 4 problems in it. One is, you can remember it by this mnemonic: pulmonary infundibular stenosis. The second is the right ventricular hypertrophy. The third is overriding aorta, and the fourth is the VSD. But the most important of these 4 components is the pulmonary infundibular stenosis. You can see it here, that from the right ventricle the pulmonary trunk is arising. That pulmonary trunk is stenosed, so blood is not able to move from the right ventricle to the pulmonary trunk and then to the lungs. So there is a problem in the oxygenation of the blood. When this stenosis, due to this stenosis, what happens is the right ventricle tries very hard to pushes the blood into the lungs and overcome this stenosis, due to which it hypertrophies. So the second thing is right ventricular hypertrophy, and that right ventricular hypertrophy, that causes a boot-shaped heart. So there is a boot-shaped heart on chest X-ray in the tetralogy of Fallot. And then there is an overriding aorta. If you look at aorta, the third component here, the aorta arises from both the right ventricle and the left ventricle. So there is again mixing of the blood. And then there is a VSD, and this VSD, whenever there is we need like increased blood in the systemic circulation due to exercise, or when there is infection or there is any stress in the body, we need increased blood flow. But because of the stenosis, the blood flow is not going to the lungs. Instead it goes into this VSD, and again this mixing happens. So that's why in the tetralogy of Fallot, what happens is there is a VSD, but that VSD is usually non-restrictive. It means that the murmur, we know that the VSD causes a holosystolic murmur. So that due to non-restrictive VSD means that the defect in the septum is very large. Due to very large defect in this septum, the intensity and the loudness of that murmur is quite low. And we have studied that in the previous video, that whenever there is a small VSD, it causes very loud murmur, and there is a large and non-destructive VSD, it causes a faint murmur. So due to increased resistance to blood flow from the right ventricle to the pulmonary trunk, what happens is that the blood flows through this VSD, and this causes the deoxygenated blood to reach the body. So in severe obstruction there will be severe stenosis, and in the mild obstruction there will be less stenosis. That is known as pink tits. So what happens is, normally the squatting or knee to chest position, it helps in the patients with tetralogy of Fallot. How? When we squat, the systemic vascular resistance increases. When the systemic vascular resistance or the total peripheral resistance, it increases, so the pressure increases in the left ventricle. The pressure increases in the left ventricle. When here the pressure is more, so this shunt, this VSD, this does not allow the blood to flow from the right ventricle to the left ventricle, because the pressure in the left ventricle is so much that it opposes that flow. So eventually the blood is redirected towards this stenosed pulmonary trunk, and it goes towards the lung. So it helps in better oxygenation. Whenever there is increased total peripheral resistance, the blood on the left side of the body increases, due to which the blood flow across the VSD is decreased, and the blood flow is redirected through the stenosed pulmonary trunk towards the lungs, and that causes better oxygenation. It is also associated with Digeorge syndrome. We have studied that in previous video. The treatment of this includes oxygen, beta blockers that reduces the spasm in this infundibular area, and also there is a knee to chest position that helps in this tetralogy of Fallot. So Whenever the child cries or there is fever or there is due to exercise there is increased blood demand, what happens is that the right ventricular outflow, it is exacerbated, this obstruction is exacerbated and the child goes into death spells. So the next disease is total anomalous pulmonary venous return. So what happens is normally the pulmonary veins, where they drain into the left atrium, but here the pulmonary veins, they are draining into the right side. So they go into the lungs, and again from the lungs they go into the right atrium and then the left ventricle. So the right ventricle, sorry. So this way the right atrium and the right ventricle keeps on dilating. So the pulmonary veins drains into the right side of the heart and they keeps on dilating. So it is associated with ASD or sometimes a PDA to allow the right to left shunt and maintain the cardiac output. That is, but that also decreases the oxygen content because mixing occurs. The last one is the Epstein anomaly. What happens in the Epstein anomaly? That there is downward displacement of the tricuspid valve into the right atrium, and so that causes atrialization of the ventricle, means the ventricle, if this is the right side of the heart and the tricuspid valve, it moves down, so it atrializes the ventricle. So it is associated with tricuspid regurg. So this leakiness of the valve occur and the right atrium pressure, it keeps on rising, and also it dilates the right atrium. So due to that dilatation, an accessory conduction pathway develops, and there is a right-sided heart failure as well. It is caused by the lithium exposure in utero. This is important. The next is the congenital heart conditions, which are acyanotic, means they are there is no cyanosis at birth, but cyanosis do develop later in life due to reversal of the shunt known as Eisenmenger syndrome. What happens in Eisenmenger syndrome, that uncorrected left to right shunt, for example ASD, VSD and PDA, what happens is that if there is a VSD or there is an ASD or there is a PDA, so what happens is that the blood flow on the right side increases because the left sided pressures are more and the right sided pressures are low. So constantly there is a flow of blood from the left sided to the right sided, which increases the right sided pressure eventually, and this blood it increases back pressure in the lungs and the pulmonary vasculature. So the pulmonary vasculature, it becomes thickened, and when the right sided pressure reaches to a point that it exceeds the left sided pressure, this shunt reverse and it is no longer from left to right but instead from right to left. And whenever the blood moves from right side to the left side, what will happen? Deoxygenated blood will reach to the body, so the shunt will reverse and the cyanosis will develop later in life, that pulmonary blood flow increases and it causes pathological remodeling of the vasculature. Pulmonary arterial hypertension develops, and to overcome this, when the right ventricle pressure is more in the left ventricle, so later on cyanosis, clubbing, polycythemia, it develops, but it happens very late in life, usually before development of Eisenmenger syndrome. It is treated. So the first one of the acyanotic heart diseases, which is very common in frequency, is the VSD. What happens is, in VSD there is a septal defect between the ventricular septum, so the blood moves from the left ventricle towards the right ventricle. So it is asymptomatic at birth, but it manifests later in life. It may resolve, but large lesions, it requires treatment. So the right sided heart, it is overloaded with blood. So the VSD, the size of the VSD matters. If the size of the VSD is small, we call it restrictive type, and there is a very loud murmur at the small shunt. And whenever there is large VSD, it is non-restrictive type, the murmur is very faint. So whenever the blood flows from the left side to the right side, eventually the right sided pressure increases so much that the blood flow in the pulmonary circulation, it should normally be 1:1 in the systemic and the pulmonary circulation should be 1:1. So whenever this blood in the pulmonary circulation exceeds the systemic circulation, the pulmonary hypertension develops, and oxygen saturation is increased in the right ventricle and the pulmonary artery because it is getting more blood from the left side. What happens in the atrial septal defect, that there is a defect in the interatrial septum. What happens is there are two types of defects in the ASD. One type of defect is called septum primum defect, and the other type is called septum secundum defect. So in the septum primum type defect, it is either due to excessive reabsorption of this septum that it leaves a defect here, or in the septum secundum defect, what happens is that the septum secundum, it is too short. So whenever there is septum secundum type defect, it is most common one, and it is isolated defect. There is no other defect associated with this. But in case of septum primum defect, it is not isolated defect, it is associated with some other defects as well. It is written here that whenever it is associated with Down syndrome. Why? Because it is associated with Down syndrome because whenever there is a problem in the ostium primum, that is because the ostium primum does not fuse with the endocardial cushions here. So whenever there is a problem with the endocardial cushions, that is seen in the AV cushion defect as in the Down syndrome. So it is not an isolated defect, it is associated with some other defects as well. So whenever there is defect in the interatrial septum, then there is a murmur associated with ASD known as a fixed wide split in the S2. Why this split happens? Normally we have studied that there is a physiologic split, that during inspiration what happens is the intrathoracic pressure, it decreases, it sucks the blood into the right side of the heart, which increases venous return. So whenever the venous return increases during inspiration, so it results in the pulmonic valve closing later than the aortic valve. Why? Because the right side of the heart is filled with blood, so it will take more time for the pulmonic valve to close than the aortic valve. And normally during expiration what happens is that there is A2P2, but during expiration what happens is there is a split. A2 comes earlier and P2 comes late. This is physiologic. But what happens is in the atrial septal defect, there is a wide fixed split of S2, that even if there is inspiratory phase or expiratory phase, it doesn't matter. In both the phases, even in the expiration, there is a split. Normally there is no split in expiration and there is a split in inspiration, but here in both the phases there is a split. Why? Because the septum is open and the right side of heart is getting more blood, and the pulmonic valve is taking longer to close than the aortic valve in both the phases, because the blood is more on the right side in both the phases. So there is a fixed wide split of S2. So ostium secundum defects are most common and usually isolated, while the ostium primum are rarer and so occurs with other cardiac anomalies. The symptoms range from none to heart failure, distinct from patent foramen ovale. So the patent foramen ovale is a different thing and atrial septal defect is a different thing. The oxygen saturation, it increases in the right atrium and the right ventricle. Why? Because it is receiving the blood from the left atrium and the left ventricle and pulmonary artery, and there may be paradoxical emboli. It means that the emboli, it bypasses the lungs and it reaches the systemic circulation through this defect. So it causes paradoxical emboli. And what happens in the patent ductus arteriosus, that there is a shunt from the pulmonary artery to the aorta, because in the fetal life the right sided pressures are more than the left sided pressures, so the blood from the pulmonary artery goes into aorta and this way it bypasses the lungs. But after birth what happens is the low due to loss of the low pressure circulation, that is placenta, and also due to loss of prostaglandins from that, and due to a decrease in the resistance in the lungs and increase in oxygen saturation in the lungs with first cry, what happens is that shunt closes. Functional closes occurs from 18 to 24 hours, and then the anatomical closes occurs weeks and few days after that, and it becomes a ligamentum arteriosum. So in some conditions, like in the congenital rubella syndrome or Todd's infection, if the mother develops fever, rash, lymphadenopathy, similarly the baby in this disease develops deafness, cataracts, cardiac defects. So one of it is the patent ductus arteriosus. It also develops patent ductus arteriosis, that the ductus remains open. So when it remains open, what happens is, now after birth the left sided pressures are more than the right side, so the shunt reverses and the left sided blood is going to the right side. So when it causes progressive right-sided hypertrophy and or left ventricular hypertrophy and heart failure as well. Now this murmur is outside the lungs. Normally the murmurs are either systolic or diastolic because they occur in the heart and they are associated with the valvular heart conditions, but here it occurs outside the heart, between the pulmonary artery and the aorta. So it is a machine-like continuous murmur, and sometimes we therapeutically keep this open in the condition like tetralogy of Fallot, and in the condition like tetralogy of Fallot and similarly pulmonary atresia, we keep it therapeutically open so that it allows the blood flow to the lungs and keep the patient alive. One thing is that there is a wide pulse pressure in the patent ductus arteriosus because of the loss of volume in the arterial tree through this PDA. The pulse normally goes on like this, but in the patent ductus arteriosus, if it's systole, it comes here, so in the diastole it comes very low, so the pulse pressure is too much increased. So the pulse pressure is increased. So this type of it causes cyanosis later in life and causes differential cyanosis. It means that the toes are blue but the fingers are normal, so it causes differential diagnosis. And the last one is coarctation of aorta. In coarctation of aorta, what happens is that there is narrowing of aorta. You see this narrowing of aorta near the exertion of the ductus arteriosus. So based on this, the position of the ductus arteriosus, there are two types of coarctation. One is the preductal and the other is the postductal. The postductal is also known as adult type. So and it is most common as well. In the postductal, what happens is that this coarctation of aorta, it occurs after the ductus arteriosus. So in this type of disease, the ductus do not supply the lower extremities. So the collaterals develops, and the lower extremity, there is lower blood pressure, and due to that renin release happens and there are weak pulses. So in the upper extremity there is hypertension and high BP. So this is also one of the conditions that is required for secondary hypertension. In the preductal or infantile type, what happens is that the ductus supply the lower extremities. Preductal, how is it? The preductal means that, for example, this is the brachiocephalic artery, then this is the left carotid, and this is the subclavian. So the coarctation of aorta is preductal. It occurs here, and after that there is a ductus arteriosus. So in this case, the ductus arteriosus supply the lower extremity. So it because it is supplying the lower extremity, there is poor development of collaterals, and the lower extremity cyanosis may occur. But the real problem happens when the ductus closes. So now all that blood has to go through that narrowed opening. So abrupt increase of afterload and left ventricular and diastolic pressure happens, and the body goes into shock. So now you might be thinking that the patient will be flushing with blood in the upper extremity and little blood in the lower extremity in a patient with coarctation of aorta, but this does not happen due to autoregulation. For example, we have studied this equation that Q is equal to change in P by R. So in the upper extremity, what happens is that there is autoregulation due to increase in difference in pressure. What happens is the resistance increases, the arterioles constrict, and in the lower extremity there is low blood flow and less engine pressure, due to which the arterioles dilate. So due to autoregulation it compensates. Now what happens is, this type of disease is associated with Turner syndrome, in which there are webbed neck and XO, this is the chromosomes, and there is hypertension in the upper extremities. The lower extremities are cold and weak, and there is delayed pulses, brachiofemoral delay. This is very important. And with age, the intercostal arteries enlarge and collateral circulation develop. Due to this collateral circulation, what happens is, if you see on the X-ray, there will be notching of the inferior borders of the ribs like this. So notched appearance on the chest X-ray. The complications include heart failure, increased risk of cerebral hemorrhage. Berry aneurysms are associated with coarctation of aorta, aortic rupture, and possible infective endocarditis. Thank you.